patient known to have diabetes mellitus since 10 to 12 years, and she takes oral hypoglycemics for diabetes mellitus. She took glucofage 500 milligram TDS, and she is known hypertensive since 10 to 12 years. For that, she takes tinarmin tablet 50 milligram OD, and she is known ischemic heart disease. His primary PCI to RCA done in August 2018, and his LHC shows her LHC shows 3VD at that time. Now at that time the culprit vessel is RCA. This was reversed, and she was discharged home. Sir, patients.
And that was which year?
2018, August 2018. Sir, and LHC was 3VD at that time. Okay. Patient complaints of chest pain. Now she presented his complaint of chest pain and shortness of breath. Her symptoms are from last 1 year, despite of taking medicines and optimized medicines.
But his revascularization was done in 2018.
Yes.
And last 1 year,
she has symptoms of chest pain and shortness of breath. And his symptoms increased in intensity since last 3 days. So she presented here with complaint of chest pain and shortness of breath. ECG done, which shows the no acute ST2T changes. His blood test done, which shows the troponins. The first troponins was 1.14 and second is 1.34. So we have admitted this patient with the diagnosis of non-ST elevated MI.
Now you have a patient with the background of ischemic heart disease for last 4-5 years.
Yes.
And she's presently with non-ST elevation MI. Now how you plan for her? What things you will look for prior to planning management?
First of all, we will look for his general status of the patient.
Okay.
Then we will look for the complaints of patient, how she is complained about his treatment. Before we do other stenting, we have to look for complaints and the treatment of the patient. And
one more important things you have to look for, because right now what we are planning in terms of her clinical status, she is presently with non-ST elevation MI with the background of ischemic heart disease and stenting as well. So this is clear that we are planning some intervention, delayed invasive or maybe early invasive kind of thing. Now prior to planning that intervention, what is the important thing you need to know?
Sir, first of all, we have to look the general status of the patient.
This is you have to look for in every patient. But I am asking specifically with this background. Would you like to review the CD?
Yes, sir. Surely I will.
Because you yourself said that this patient had
3VD.
Previously having 3 vessel disease. And her PCI of RCA was done at that moment.
Yes.
But in spite of that, she remained asymptomatic according to your history. And started having symptoms for last 1 year. But we would like to know what were the symptom status in last 1 year, the progression of those symptoms as well. So what was that?
Sir, initial symptoms are on exertion. Sir, now
So you have to correlate it with CCS 1, 2, 3. That will make it more objective to understand.
Yes.
So 1 year back she started having symptoms.
Symptoms of CCS class 2.
2.
Yes.
And what is CCS 2?
CCS 2 chest pain with more than ordinary activity she gets the symptoms.
Yeah. Slight limitation of routine activity. And what is 1?
No limitations of ordinary activity.
So no symptoms on routine activity. You have symptoms once you do more than routine or some extraordinary strenuous exertion. And what is 3?
Some limitations on marked limitation
of routine activity, but not at
rest.
And 4?
At rest, patient gets symptoms.
And that is very important. This class, always remember when you are assessing in OPD, anywhere, try to gauge symptoms according to this class. And easiest way is to ask, भाई आपको routine के चलने फिरने में कोई तकलीफ होती है? मरीज कहेगा नहीं, कुछ नहीं होती. एक वो मरीज होगा. This is 1. और कब होती है? जब मुझे कभी 5 मंजिलें चढ़नी पड़ गई, कभी बहुत तेजी से कहीं चलना पड़ गया, तो this is 1. That no symptoms on routine, but when he do more than routine, he got symptoms. 2 क्या होगा? हाँ, हफ्ते में एक मर्तबा कभी थोड़ा बहुत दर्द हो जाता है, थोड़ा सा रुकता हूँ, फिर चल पड़ता हूँ, सब कुछ कर लेता हूँ. ये 2 हो गया. 3 कौन सा वाला होगा? रोजाना
डेली एक्टिविटी.
जब भी मैं 10 कदम, 15 कदम, 20 कदम से आगे जाता हूँ, तो दर्द होता है, रुकना पड़ता है, फिर चल पड़ता हूँ, बस इस तरह ही चल रहा है. सो रूटीन, प्रिडिक्टेबल, मार्क लिमिटेशन ऑफ रूटीन.
activities.
एंड 4 इज सोते हुए हो जाता है, बैठे बैठे हो जाता है अचानक, सो फोर्थ. So why is it important? Because that tells you about your management strategy. Is it working or not? So let's see someone in this background, like this patient. That ये अगर साल पहले आपके पास आती, so what you have done? That साल पहले मतलब कि she started having symptoms on some
Exhaustion.
exertion, and prior to that she was completely
Asymptomatic.
normal. So what you would have done at that moment?
Sir, first of all, I will look the CD at that time. If patient has symptoms of CCS class 2 or 3, as she already mentioned, I know the status because his LED is 100% at that time. We will directly go for revest at that time.
No. She is a stable IHD patient. In stable IHD, you have to optimize your treatment strategy. And first, optimization of treatment strategy means what are the steps of managing a stable IHD? Because someone with the background of stenting, asymptomatic with that same anatomy for 3 years, and now started having CCS2 angina. So how you optimize the treatment?
So first of all, we will control his symptoms and rate of this patient. If rate is more
Rate, yani first lines are beta blocker and
nitrate
calcium,
channel
no, calcium channel blocker, or calcium depending on rate status. If your patient is rate is fast, then rate limiting calcium channel blocker and beta blocker. If LV dysfunction is there, then beta blocker and ivabradine, not rate limiting calcium channel blocker. Rate kam hai, then beta blocker and vasodilatory calcium channel blockers. Then second line is optimum nitrates. Let's see, you have given optimum nitrates as well. What is the third line?
Ivatip.
Depending on
Depending on
patient's hemodynamics. If pressure is low, heart rate low,
Then
renolozine or trimetazidine. If heart rate still fast, pressure low, then ivabradine. If heart rate, pressure both available, then rate limiting calcium channel blocker, optimization, beta blocker. So that's the way to go about. And in this patient, certainly right now we need to review the CD first, because we have to preempt as well that after angio what we expect, then plan accordingly. So
can we go for MPS in these patients?
no, she is non-ST. So now one category is MPS if she remains asymptomatic after the event. She is having LV dysfunction. Then you need to assess viability and other things. But if she continue to have pain, ongoing angina, then revascularization, no MPS.
I am asking about this patient. If our primary diagnosis at this moment is non-ST elevated MI, and we know the status of this patient is, we know that her LED is LED. LED is 100%. Then without going to other non-invasive, shall we go for direct invasive?
Yes, I think with non-ST elevation MI, with the background of that anatomy, first we need to see the anatomical status, what wrong has happened. Then according to anatomy, we will decide what next to be done. ठीक?